I will now demonstrate extraction of the posterior arm. I have found over the last 5 years in informal surveys of audiences that half of all people delivering babies in the United States have never successfully extracted the posterior arm in a live fetus. This significantly limits their ability to deal with the more severe types of shoulder dystocias, such as when suprapubic pressure and McRoberts maneuver fail. To successfully extract the posterior arm, one must first be able to insert their entire hand into the vagina. To best reduce the diameter of one's hand and make it as small as possible, one must palm the thumb as I am showing. Some people have likened this to trying to put your hand into a Pringles potato chip container and thus have named it the Pringles maneuver. The vagina is then entered at the 6 o'clock position and the posterior humerus should be located and the humeral shaft traced to the antecubital fossa. Please note here that my entire wrist is now through the vaginal introitus. The thumb should come to rest in the antecubital fossa and the forefingers around the forearm up to the level of the wrist. The antecubital fossa should then be pressed with the thumb and the forearm flex. This will give the delivering attendant access to the hand and forearm. At this point, grasping the wrist with the thumb and forefinger, which I have found is the most appropriate point for traction, one simply needs to pull the hand through the introitus in a simple, straight outward motion. The shoulder will automatically rotate as the hand comes outside the introitus, and then the next maneuver is simple downward traction on the fetal head as the obstructing wedge has been relieved. This particular model, the prompt birthing trainer, is particularly good for allowing delivery attendants to test whether they can use both hands to deliver the fetus when extracting the posterior arm, or whether they have to use their dominant hand. In this demonstration, I will show how to best determine which of your hands to use for extraction of the posterior arm. For example, in the current position, you see that use of the right hand to extract the posterior arm makes tracing the humeral shaft more difficult than if one were using their left hand. Delivery attendants should practice using their non-dominant hand to extract the posterior arm. I believe this is a particularly important aspect of simulation training of posterior arm delivery for shoulder dystocia management. I will now demonstrate the removal of the posterior arm in the uncommon circumstance where the posterior arm does not lie in the ventral part of the fetal chest but is trapped behind the dorsum. I have moved the anterior arm on the model for better visualization and filming. In this technique, when the posterior arm is approached, the delivering attendant will usually find that tracing the humeral shaft leads one to the fetal back. This is indicative of a trapped arm, typically against the sacral promontory or against the posterior part of the pelvis. There are two approaches to this problem. The first is to purposefully fracture the humerus by inserting the index finger to the midpoint of the humeral shaft and then attempting to draw the arm across the body. Usually a palpable snap will be felt and sometimes heard, and the arm can then be manipulated into the ventral part of the fetus and then extracted in the usual technique. Sometimes in bilateral shoulder dystocia both arms are trapped, and in this position the delivering attendant will have to further insert their hand into the vagina to the point that you see now, where my entire wrist and part of my forearm is in the vagina and my fingers extend past the elbow. At this point in time, the forearm can be splinted and grasped, and with pressure on the forearm and elbow, the arm manipulated across the body until it lies on the ventral part of the fetus. The wrist can then be grasped as it would in a normal fetal posterior arm extraction, and the hand extracted by pulling straight out. The rest of the fetus is then delivered.